Gastroesophageal reflux disease, or GERD, is one of the most commonly diagnosed digestive disorders. Many clinicians feel confident making this diagnosis based on a patient's symptoms, especially when heartburn is present. But is it always that simple? Today, we'll explore the difference between real and fake reflux, why misdiagnosis is so common, and how a thorough evaluation can make all the difference. Let's dive into the complexities of refractory GERD and uncover why some patients continue to suffer despite treatment. GERD stands for gastroesophageal reflux disease. It's a condition where stomach acid frequently flows back into the esophagus, causing symptoms like heartburn and regurgitation. While these symptoms are classic, GERD can also present with less typical complaints such as cough, chest pain, or even laryngitis. Because of this variety, GERD is often diagnosed based on symptoms alone, but, as we'll see, this approach has its pitfalls. When a patient complains of heartburn, most clinicians start with acid-reducing medications, such as proton pump inhibitors. Endoscopy is usually the first test performed, under the assumption that it will provide useful diagnostic information. However, more advanced tests like esophageal manometry and pH monitoring are rarely done early on. This standard approach is considered adequate for routine care. But is it truly reliable? Unfortunately, relying solely on symptoms and initial endoscopy leads to a significant rate of misdiagnosis. Studies show that up to 30 to 40% of patients thought to have GERD actually have another underlying cause for their symptoms. This means that many people are treated for GERD when they don't truly have it, while the real problem goes unaddressed. The term refractory GERD is used when patients continue to experience symptoms despite taking acid-reducing medications. But not all persistent symptoms are due to ongoing reflux. Some patients have real reflux true GERD that isn't controlled by medication. Others have fake reflux symptoms that look like GERD but are caused by something else entirely. Distinguishing between these two is crucial for effective treatment. To avoid misdiagnosis and unnecessary treatments, a complete diagnostic workup is essential. This includes not just endoscopy, but also barium swallow studies, esophageal manometry, and pH monitoring. These tests help clarify whether symptoms are truly due to acid reflux or if another condition is at play. Especially when surgery is being considered, skipping these steps can lead to poor outcomes. Symptoms alone are not reliable for diagnosing GERD. Heartburn, regurgitation, and even chest pain can be caused by many different conditions. Studies show that the sensitivity and specificity of symptom-based diagnosis are only around 62% and 67%, respectively. This means that relying on symptoms alone will miss many cases and mislabel others. A common diagnostic tool is the proton pump inhibitor, or PPI, test. Patients are given a short course of high-dose acid suppression to see if their symptoms improve. However, studies show that a positive response to PPIs is not specific for GERD. Many patients without GERD also feel better, leading to further diagnostic confusion. Esophageal manometry and pH monitoring are specialized tests that provide objective data about esophageal function and acid exposure. In a large study, nearly one-third of patients with a clinical diagnosis of GERD had normal reflux scores on these tests. Many of these patients were found to have other conditions, such as gallstones, irritable bowel syndrome, or even heart disease. Some patients with persistent heartburn actually have achalasia, a disorder where the esophagus fails to move food properly. These patients often don't respond to acid-reducing medications and may be misdiagnosed as having refractory GERD. Proper testing reveals the true cause, allowing for the correct surgical treatment, such as helemyotomy. Before considering anti-reflux surgery, it's critical to perform esophageal manometry and pH monitoring. These tests can rule out motility disorders like achalasia and confirm whether abnormal acid exposure is truly present. Skipping these steps can lead to unnecessary or ineffective surgery. Endoscopy is a valuable tool for assessing the esophageal lining and ruling out other diseases like ulcers or cancer. However, fewer than half of patients with typical Gerd symptoms have visible mucosal lesions. There's also significant variability in how mild esophagitis is interpreted, making the diagnosis less reliable. The Los Angeles, LA, classification system was developed to objectively grade the severity of esophagitis seen on endoscopy. It ranges from grade A, the mildest, to grade D, the most severe. However, grades A and B are often difficult to distinguish, and many patients with Gerd symptoms have no visible damage at all. Barrett's esophagus is a complication of chronic Gerd, where the lining of the esophagus changes. It's considered a strong indicator of pathologic reflux, but even here, diagnosis can be tricky. Only about half of patients with short-segment Barrett's have biopsy confirmation, highlighting the need for careful evaluation. To further clarify Barrett's esophagus, the Prague classification system distinguishes between long and short segments. Long segment is defined as 3 centimeters or more, while short segment is less than 3 centimeters. This distinction is important for risk assessment and management. A thorough diagnostic approach is the key to successful treatment. Medical therapy helps most patients, but for those with persistent symptoms or those considering surgery, a complete workup is essential. This ensures that the right patients receive the right treatment and that unnecessary procedures are avoided. When anti-reflux surgery fails, it's often due to incomplete preoperative evaluation, incorrect indications for surgery, or technical errors during the procedure. Proper patient selection and thorough diagnostic workup are among the most important factors for success. Expert panels recommend that all patients with foregut symptoms, especially those being considered for surgery, undergo a comprehensive evaluation. This includes symptom assessment, barium swallow, endoscopy, manometry, and pH monitoring. For certain patients, additional tests like gastric emptying studies or bronchoscopy may be needed. A 4-hour gastric emptying study is reserved for patients with significant nausea, vomiting, bloating, or when retained food is found in the stomach during endoscopy. This test helps identify delayed gastric emptying, which can mimic or complicate Gerd symptoms. In patients with idiopathic pulmonary fibrosis, bronchoscopy with bronchoalveolar lavage and pepsin assay can help determine if aspiration is present. This is important because reflux-related aspiration can worsen lung disease and targeted treatment may be needed. When patients continue to have symptoms after anti-reflux surgery, it's often assumed that the operation has failed and acid-reducing medications are restarted. However, studies show that most of these patients do not have ongoing pathological reflux. Early use of esophageal function tests can prevent unnecessary and costly treatments. In one study, only 23% of patients with symptoms after Nissen fundoplication had abnormal acid exposure on pH monitoring. Similarly, another study found that just 32% of patients taking acid-reducing medications after surgery actually had reflux. These findings highlight the unreliability of symptoms alone in diagnosing recurrent Gerd. Ambulatory pH testing is a key tool for evaluating patients with persistent symptoms after surgery. In one study, only 9% of patients with Gerd-like symptoms after fundoplication had pathological reflux on pH testing. This underscores the need for objective assessment rather than relying on symptoms alone. Across multiple studies, the message is clear. Symptoms after anti-reflux surgery are an unreliable indicator of ongoing reflux. Esophageal function tests, including manometry and pH monitoring, should be performed early in the evaluation to avoid unnecessary medications and interventions. Misdiagnosing GERD leads to unnecessary treatments, increased healthcare costs, and ongoing patient suffering. By ensuring a thorough diagnostic workup, clinicians can provide more effective, targeted care and avoid the pitfalls of treating the wrong condition. Selecting the right patients for anti-reflux surgery is critical. Only those with confirmed pathological reflux and no significant motility disorders should undergo surgery. This careful selection process leads to better outcomes and fewer complications. A barium swallow study is a non-invasive imaging test that helps visualize the esophagus and stomach. It can identify structural abnormalities, motility disorders, and sometimes even reflux. This test is an important part of the comprehensive evaluation for GERD. Esophageal manometry measures the pressure and movement of the esophagus. It helps diagnose motility disorders like achalasia and ensures that the esophagus is functioning properly before surgery. This test is especially important for patients with atypical symptoms or those not responding to standard therapy. pH monitoring tracks acid exposure in the esophagus over a 2-4 hour period. It's considered the gold standard for confirming GERD, especially in patients with persistent symptoms or those being considered for surgery. This test provides objective evidence of abnormal acid reflux. Surgery is considered for patients with persistent symptoms despite optimal medical therapy, or for those who achieve complete symptom resolution with medication but prefer a surgical solution. However, only patients with confirmed pathological reflux should undergo surgery to ensure the best outcomes. Even with the right diagnosis, technical aspects of anti-reflux surgery are critical. Surgeons must follow proper steps to ensure the procedure is effective and safe. Failure to do so can result in persistent symptoms or complications. After surgery, patients should be monitored for symptom resolution and possible complications. If symptoms persist, objective testing with manometry and pH monitoring should be performed before making further treatment decisions. Many patients are prescribed acid-reducing medications after surgery based solely on symptoms. However, studies show that most of these patients do not have pathological reflux. Objective testing can help avoid unnecessary and costly medications. For patients, persistent symptoms can be frustrating and confusing. Clear communication about the diagnostic process and the reasons for each test can help patients feel more informed and involved in their care. This partnership leads to better outcomes and satisfaction. Clinicians face the challenge of distinguishing real reflux from mimicking conditions. A careful, stepwise approach using objective tests is the best way to ensure accurate diagnosis and effective treatment, minimizing unnecessary interventions. Managing refractory GERD often requires a team approach. Gastroenterologists, surgeons, radiologists, and sometimes pulmonologists work together to ensure that all possible causes are considered and the best treatment plan is chosen. Educating patients about the limitations of symptom-based diagnosis and the need for thorough testing is crucial. When patients understand the process, they are more likely to adhere to recommendations and achieve better outcomes. To summarize, diagnosing GERD and distinguishing real from fake reflux requires a stepwise approach. Start with symptom assessment, then proceed to endoscopy, barium swallow, manometry, and pH monitoring as needed. Each step adds valuable information to guide treatment. Real reflux is confirmed by objective evidence of abnormal acid exposure, while fake reflux refers to symptoms that mimic GERD but are caused by other conditions. Recognizing the difference is essential for choosing the right treatment and avoiding unnecessary interventions. Accurate diagnosis leads to better patient outcomes, more effective treatments, and lower healthcare costs. By using a comprehensive, objective approach, clinicians can ensure that patients receive the care they truly need. Research continues to improve our understanding of Gerd and its mimics. New diagnostic tools and biomarkers may soon help distinguish real from fake reflux even more accurately, leading to even better patient care. Gerd is a complex condition that requires careful evaluation. Symptoms alone are not enough for diagnosis. A thorough, stepwise approach using objective tests is the best way to distinguish real from fake reflux and ensure effective treatment. By understanding the limitations of symptom-based diagnosis and the value of comprehensive testing, both patients and clinicians can work together to achieve the best possible outcomes. Empowerment through knowledge is the In summary, diagnosing and managing refractory Gerd requires more than just treating symptoms. A complete diagnostic workup, including endoscopy, barium swallow, manometry, and pH monitoring, is essential for confirming the diagnosis and guiding treatment. By distinguishing real from fake reflux, clinicians can avoid unnecessary treatments and improve patient outcomes. Thank you for joining us as we explored the complexities of refractory Gerd. Remember, accurate diagnosis is the cornerstone of effective treatment. Whether you're a patient or a clinician, understanding the difference between real and fake reflux can make all the difference in achieving lasting relief and better health.